but our jacarandas have just popped out. So
Jacaranda. Looks
it's
awesome.
gorgeous. It's gorgeous.
Yeah.
Yeah.
Man, we used to have one of those in my old house. How's that, huh? What a glorious
Yeah.
thing to see.
Yeah.
That's a jacaranda style place to be. Now, what's on for your day today?
Well, mate, our admin day, our day of just stepping outside of the office and being able to, having the luxury to focus on some of these amazing projects that we're really passionate about. And I think that's what keeps work really satisfying now. It's not just doing the grind of seeing patients and operating, but also being able to dedicate some time to these passions, and as we probably both agree that back pain and musculoskeletal health is a bit of a passion of ours.
Well, I had a little practice once of seeing how much instant coffee I could actually handle as a pre-workout. This was a situation where I was testing myself as a young kid and just adding more and more. I got up to the point where 8 teaspoons of instant coffee was acceptable, but 10 was heart palpitations. So
10,
that was sort of 10
as a pre-workout in one drink or throughout the day.
No, it was in one workout. Yes, one drink, one shot. That
Your
was
heart
the end of
rate
my experiment.
Your heart rate would be like over 100 before you even started your first rep.
That's what life's about. It's like testing out the edges and testing the limits and finding the boundaries.
Sensational,
And
man.
Sometimes we survive.
I try not to have any coffee after midday. Or I try not to have any caffeine. In fact, I learned a little bit from this fellow called Professor Matthew Walker.
Okay.
And he's supposed to be the world's guru on sleep. And he says that if you have a standard cup of coffee after midday, it's with the half-life of caffeine, it's the equivalent of having 1/4 of a shot of caffeine in your bloodstream at midnight.
The technology keeps getting better, just like with backs, huh?
Yeah, absolutely. I think in a way we're kind of taking the technology backwards, back to fundamentals. It's that's the profound thing about our ideology, is that we're trying to teach people to focus on the fundamental requirements rather than think about advanced methods and all of the gizmos that are out there that sort of supposedly fix back pain. And the technologies of surgery. Like, if you're needing to consider surgery to help your spine, then you've kind of been let down by the industry.
Let down by the industry, the world's education, and perhaps even your own sense of responsibility of what you be doing. There's a lot of variables in each case, isn't there?
Well, Andrew, tell us a little bit about your clinical experience over the years. In a relatively nice, concise summary. I know that's very hard, but go for it.
Well, they always come from the experience of having your own pain. I really think it's hard not to have an experience yourself to really grasp the importance of what you're going to be teaching. So for me, I was doing one-arm dumbbell rows with 200-pound dumbbell one day in the gym, and did 10 repetitions on the right hand and did 9 on the left, and went for the 10th one, and significant low back pain occurred. And that was the precursor to 2 years of not being able to walk properly. That was a huge disc extrusion that occurred at that point. And it was a great opportunity because it was very close to the time when I just graduated. And the experience really comes in there of, I went to do the postgraduate Mackenzie program as well, completed that to the credentialing level, learned a lot in the process. And from there, it's been a never-ending quest. As I said, one of the greatest pieces of advice I was given was my first day in private practice was the office manager, the practice manager, she took me into the office and said, your job here is to become the best in the world at something. And she said she was the best in the world at shoulders, so I had to choose something else, and that was backs for me. So it's been an ongoing quest since 1994 to learn everything and know everything that can possibly be done. And there is so much information we understand. And that's what's driven me, especially towards the college, is because I'm seeing that the graduates and the education and the academia seems hell-bent on ignoring science, biology, biomechanics, physics, the things that actually we construct our world with. The academic world seems to be trying to not introduce it to the students. There is thousands of years of evidence of people getting hurt in certain positions and postures. So my experience through a lot of sports and now my professional life is trying to bring this education, which seems to be like the Wizard of Oz. Don't look behind the curtain, our academics are telling people. There is so much work. And that's my mission now, is to bring the successful techniques, movement pattern proficiency to everybody. And taking it away from just the private practice and educating professionals to become competent and excellent and solving the recurrent low back problem. Now, what about yourself? I mean, it's such a interesting story for a man to become a neurosurgeon and suddenly go, we need to teach people how to move. What was the aha moment for you?
I'll introduce that, but just on your intro there, Andrew, it's very interesting that your episode of back pain happened very suddenly with a we could call that a incidental or accidental poor biomechanical movement task that created your pain. But there's lots and lots of people that just sort of develop their pain over years, and I think it's a salient point to be able to highlight that the development of back pain can occur very suddenly, or it can occur slowly and steadily over time. The underlying principle behind why you feel that pain and disability fundamentally is no different. It's just the time scale is different. It can happen in 1 second. You fall down the stairs, or you pull a dumbbell up poorly, or you have repetitive bad movements in an accumulative manner, which then still drives the same outcome. The end result is the same: structural compromise, which then causes your pain and disability. And the solution to that is still reverse engineering the problem. Let's avoid the biomechanical movement dysfunction, and then we can either prevent the injury from happening in the first place, or if you sustain an injury, promote optimal and maximal healing of the injury. So yeah, that was just interesting to hear that your symptoms developed all of a sudden. I mean, I absolutely agree that having experienced back pain makes you, and working in the industry makes us think about it hard, because we should be people who know the answers if we're treating patients. But my experience with back pain is more on that other end of the spectrum, where it's slowly developed over time, and I'm sort of going to work or finishing finishing an operation and going, geez, my back really hurts now, and I'm struggling to get back into my car at the end of the day, and I'm thinking, geez, what's going on here? Why am I getting back pain? I should be able to prevent myself from getting back pain. And then the penny starts to drop that treating back pain is not about addressing the symptoms, which is kind of what our education and our advanced education has been teaching us all this time, how to address the symptoms, but actually to effectively address the cause. And that's a principle that's relevant to all parts of medicine. You don't just address symptoms, you address the symptoms in conjunction with elimination of the cause. It's no different to someone who has, terrible lungs and they need a lung transplant because they've been smoking for 50 years. Yes, we give that person the lung transplant, but we also tell them to stop smoking. Okay, that's addressing the symptoms of not being able to breathe, but also addressing the cause of why they need the lung transplant in the first place. And that's a principle that it's a tenet of medicine for every disease process. But in musculoskeletal medicine, that principle just seems to be thrown out the window. We just go, oh, you've got pain, have you? Let's implement some form of symptom-based therapy, and it may be here's a certificate to take some time off work. We give you a prescription for some pain medication. We may deliver some manual therapy, which feels fantastic, but none of the advice is, okay, well, why are you sore now? Let's address that in a very specific and distinctive way so that I don't have to see you again next month.
Biomechanical lower back pain has a cause.
Exactly right. But yeah, so back to just a brief intro of myself. My medical career started in 1990. So I'm now over 30 years of experience working and training in medical science. And then my preliminary years of medical training slowly moved me towards neurosurgery, and then advanced training, and then working as a public hospital slave for a while, and then eventually developing a private practice, which was almost wholly focused on spine and spine pain. And then, of course, when you subcategorize spine pain, there's just so many people with back pain. From a statistical point of view, we're talking 3 million people in Australia with chronic back pain today. That's nuts. That's insane.
That's just today.
Yeah. So chronicity meaning continuous pain for 3 to 6 months. Okay, that's what we sort of arbitrarily define as chronic. It's like, yeah, everyone gets a little bit of a niggle, and it, they feel their pain and it goes away the next day. That's an acute episode of pain. But in terms of accepting that there's potentially 3 million people with daily pain of greater duration than 3 months is quite profound, and it's reflected by the the Australian Bureau of Statistics and their burden of disease studies that say that back pain is one of the leading causes of disability in the country, and one of the greatest economic health burdens in the country.
One of the things I really love there is I like McGill's approach to these things that we've called chronic lower back pain, and he would term it as multiple acute episodes daily, in that there's a biological trigger within the movement patterns that a person acquires each day. And if we address those movement patterns, we solve the multiple acute triggers that are causing this person to have what we've termed chronic.
Exactly. That's fantastic. Yep, that's a really, really nice way of phrasing it. It's multiple acute episodes, and it's just like smoking cigarettes. I'll just have one cigarette, and then it's not the first cigarette that hurts you, and it's not the last cigarette that hurts you, okay, that gives you emphysema. It's all of the hundreds or thousands of cigarettes over the years, and we can appreciate that in terms of the spine. It's all of the bad movements that people engage in or express in their daily life activities. It's not necessarily just like the big heavy, lifting the plant pot up out of the boot. It's, how did I sit down? How did I stand up? How did I bend over to brush my teeth? And you add those up and you've got 5,000 bad movements a day over 10 to 20 years. You're going to suffer back pain because that's repetitive, accumulative biomechanical stress.
That's the underpinning that we understand in our sporting athletic. That's what we understand in daily life, and that's what I see has been so missing in the education system, is the understanding that poor movement patterns are accumulative. I didn't just hurt myself on that one lift. I'd set it up with a whole lot of patterns prior that large load reached the capacity that I had. Had I not had poor movement patterns prior to it, had I known what to do, I could have had technique failure and still been safe. There's
the legacy of bad movement prior that may increase your susceptibility to that smoking gun moment. But I suppose, in terms of trauma, if the trauma is bad enough, then you could be a perfectly healthy person moving well, and you get hit by a truck. That's movement dysfunction at the extreme end of the spectrum. You're still going to rupture your disc, right? But that's because it's still movement dysfunction. You got hit by a truck. Or you could have suboptimal movement patterns for a long time, and then you go to tie your shoelaces, and then your disc ruptures. The end result is the same, a disc rupture. The time frame over which it occurs is somewhat different, and the predisposed susceptibility to that smoking gun moment is different as well.
And we actually do know the mechanism of posterior disc protrusions and injuries. We know the mechanism. It's flexion under load. Intralumbar
flexion, and under load, when we're just moving our body weight, that's relative load, right? It doesn't have to be pulling a deadlift poorly, because little old grandma can still have terrible back pain if she's bending over to pick up the knitting needles repetitively poorly. So
that's right.
We're all weightlifters. This is what I like to say this to my patients. We're all weightlifters. Like it or not, you are a weightlifter. Even if you're not actually carrying a piece of iron or dumbbell or kettlebell or barbell, we're weightlifters because we are moving our body. 50% of your body weight lives above the belt line. And so if you are engaging in life, you are by definition participating in the sport of life. And the sport of life is weightlifting. You don't even have to be in the gym. You're weightlifting when you get out of bed. So if you're going to be a weightlifter, be a good weightlifter, which we know.
Technique matters.
Technique matters, and you and I, who spent a lot of time in the weightlifting gym, that's all we think about when we see something heavy. Oh shit! I better move well when I do this clean and jerk, or when I do this deadlift, or when I do this snatch movement, or when I do whatever it may be. It may be a pull-up, it may be a muscle-up, depending on what sport-specific interest you have. Technique matters. Are you a golfer, Andrew?
Terrible one.
So what can we say about your golfing technique?
My technique matters, and I'm too slow. My velocity is not good.
Yeah, and if you wanted to get mini golf, if you wanted to get better at playing golf, what would you do?
I would practice daily proficiency of movement. Maybe twice a day if I want to get really good.
Of the golf movement, and you would go and maybe hire a golf coach.
I absolutely would. Yeah.
And that golf coach has an eye for movement in respect to the golf swing, right? And we as movement clinicians, we have an eye for movement in activities of daily living. And that's the analogy, right? If you want to become good at a movement task, you go and get someone to help you with that movement task. It doesn't matter whether you want to get good at hitting a tennis serve or a forehand or a backhand or a golf ball. You go and seek out someone who knows that movement who knows how to teach your brain the motor patterns that make that movement A+, and you'll then become a good golfer. And for us as spinal clinicians, when people come to see me with their back pain, I need to be, if I'm going to be effective in my craft, I need to be able to direct that person to restore their movement patterns for what they do in life, which is get out of bed, make the bed, empty the dishwasher, go to work, sit in the car, empty the filing cabinet, and that's how I define movement therapy for tasks of daily living. And it's incredible that is such a simple concept, yet it's really only now that we're trying to get this message out there broadly. And I've been trying for a long time, but without the collaboration with people like yourself and the broader community that are tuning in, we won't succeed. We've got to draw in the community of people that we do know understand movement, hence the college, hence what we're working together on with the College of Functional Movement Clinicians.
It's so important. one of the things, because that's my job on the ground, is I'm seeing people who let's say we're trying to avoid going to surgery, or
Absolutely.
they're having the multiple acutes, as we would call them. There is knowing statistically that at least 80% of all adults are going to have lower back pain at some point in their life, but about 92% of those are going to have recurrent episodes. Now, as a professional, you can build your business on the fact that everybody's going to come back every time they tweak their back, and they're going to think you had something to do with it getting better.
Yeah.
But they haven't solved why you keep coming back to them. And that's where my approach especially has been on the ground, has been, okay, we're going to make this your last episode of lower back injury, lower back pain, by solving the movement patterns that you currently do, which is set you up, like stopping smoking. And we're going to give you movement proficiency. That, especially at perhaps even a Gen Pop level, that's going to give them daily freedom. But it's also going to give a great athlete the ability to have a movement failure under a maximum load at a maximum competition and still be safe. When their absolute training technique has taken them to the point of excellence, and they're taking themselves to the point where technique may be challenged. But if your technique's terrible all the way to that last one, you're not going to make it. That's a hallmark of all the great athletes. And it's a hallmark of great artists. It doesn't matter if it's music, does it? I mean, all the things you possibly see, dance, music, art, everything takes technique. And movement proficiency is the same as every other science.
I think there's obviously some movement theory and layers of complexity that we need to educate our community about, and they are lessons that really they relate to capacity and demand, and stability. So we could reflect back on some real life situations, like, you know, the fellow who just pulled a 501 kilogram deadlift, Haptor or something like. So you know, when he pulled that
technique too.
Well, if you were at threshold, and you know, he's clearly approaching threshold there, right? It's a world record. He's never done it before. It's at the threshold. Now, when we're at threshold, we may not look perfect in terms of what we would define as really good technique, as a movement clinician saying, yeah, that's perfect technique, I like that. As you start to approach threshold, your technique may start to crumble a little bit. But what we can say is that if you have your nice default movements and your sub-threshold, what you're actually doing is you're building that capacity and you're remaining at a sub-threshold level with good movement. So because your capacity, is building up, you're still getting closer and closer to that world record and your sub-threshold. As he approaches that capacity where the demand of the movement exceeds his capacity, you then start to introduce a risk that your movement proficiency will result in an injury. But if you are at sub-threshold capacities or sub-threshold demands, and you don't move exactly perfectly, that doesn't necessarily mean that you're going to get injured, as long as you maintain stability. And stability can be maintained in the absence of perfect form. Like, we know that we can bend over like a fishing rod, you know, or a giraffe, and we can have a lot of intralumbar flexion, and we're not going to end up in a hospital. But that's only because we've built our capacity and we've maintained our stability to do that. But the moment we try to bend over like a giraffe and pull 100 kilograms off the ground with the Jefferson curl, which is beyond our threshold of capacity and forces us to lose stability, now I can guarantee you 100% that you're going to get injured. And I think McGill showed that. McGill showed that way back when he had fluoroscopy imaging a weightlifter who was at threshold and moved poorly. And I think he actually demonstrated for the first time ever a subluxation of the vertebral body during a lift. And that person dropped to the ground with terrible pain and spasming back muscles. And that's a reflection of that concept, is that if you lose stability, you're going to get injured. And
very much it. And if you have trained a Jefferson curl and you have trained the technique well,
yes,
and your capacity is there for it,
you can do it.
And you've worked well in all other ways, you're going to be okay with that 100 kilo
Yep.
Jefferson curl because you've learned the technique.
Yep.
Now, how many people do we need to do that within our rehab protocols? Too few to actually make it significant as an answer to lower back issues.
Yeah, exactly right. And
movement proficiency is everything.
And if you say you got that person who say say that person had a arbitrarily 100 kilogram Jefferson curl, okay. If he then reverted back to really good movement patterns, which we would be supporting, in neutral spine, hip centric rotation, posterior kinetic chain powered movement, I can guarantee you that his lift would probably be triple that. He'd probably be able to lift 300 kilograms. So by definition, I think we
see it done sometimes.
Yeah, by definition, the poor movement pattern, even though he's stable, he could only do 100 kilogram Jefferson curl. But if I then put him into good movement patterns, he's suddenly pulling 300 kilograms. There's no way he could do a 300 kilogram Jefferson curl, because by definition, that movement is not adhering to the definition of what good spinopelvic movement is.
Yeah, she lacked the hip torque.
Yeah. Fortunately, when we're talking about the lumbar spine, and you're an expert at shoulders and hips and knees, and those are, very complex joints with huge ranges of motion. And so the restoration of movement proficiency in regard to those joints is quite complex. But thankfully, the most significant disability on the planet, the most significant musculoskeletal disability on the planet, back pain, the movement patterns associated with the lumbar spine are really simple. The lumbar spine is a support strut. It's a multi-segmented, semi-rigid support strut. And that's all it needs to do. That's all it needs to do. So when we're training people, or when we're rehabilitating people, or when we're training people who want to be movement clinicians, that's all they need to be able to do is transfer that skill of the motor patterns coming out of the brain into the spinal cord, into the musculature, is to maintain stability of the lumbar spine being a semi-rigid support strut in neutral positions.
That's essentially it, isn't it? And that's what we need to be able to educate professionals to be able to stop the recurrence of lower back issues.
Yes.
Is to teach those movement proficiencies and stabilities. As Julie was actually saying, she works with some older population, and one of the things she talks to them about is, are you competent and are you safe to be able to have your grandchildren left with you?
Yeah.
And if you haven't, you need to move well, because your grandkids staying with you and you might be looking after them for a while. Are you safe to pick that child up off the ground? Are you confident about it? And she has to teach them movement patterning, which makes them proficient as a part of a family unit. It doesn't even matter. It doesn't have to be the biggest weightlifter in the world, does it? It can be anybody who has a need to be able to move well and safely, not only for themselves, but also for others.
Yes. And like moving well, people say, "Oh, what do you mean I have to move well?" Like, it's like saying, when you jump in your motor car and you go for a drive from A to B, do you think about, should I drive well today? Should I drive well today, or should I drive like a maniac? Like, of course you drive well if you want to survive and avoid a crash. But and the same should be for when we're doing our daily tasks of living. Should I move my spine well today? Yes. It's completely realistic to expect that, and it's just a motor habit. It's just a motor pattern that needs to develop. And once you develop that motor pattern, it's hard to reverse it. Modern society tries to corrupt motor patterns, because we sit in an office all day, we sit in a car, we don't have to hunt for our food anymore, we don't have to prepare our food much more than stick it in a microwave. So yes, modern society is kind of responsible for why motor patterns are so bad today. And I don't know whether you've traveled abroad into non-industrialized cultures. I've been to Papua New Guinea and grew up in Papua New Guinea. I've been to northern China, Africa, and when you go to these non-industrialized cultures and you understand movement, you're looking at 90-year-old grandma and she's still got a full depth squat. You know, they don't have toilets, they squat. And you go to your local shopping center and ask someone to squat, they can't do it. Their movement patterns are corrupted, and hence the secondary musculoskeletal soft tissues are corrupted. They can't do a squat. They got to get up on their tiptoes and do a kneel or a squeal. We call it a squeal. They can't squat with their heels on the ground. And
a fundamental movement pattern.
Yeah. And then they wonder why their back hurts, because they can't actually move their body the way that it's designed to move.
Well, they spend their life avoiding those movements.
That's right. They say, oh, that hurts me, so I better not do that. What does that do? They're now on a slippery slope to oblivion and chronic pain, you know, because if you don't do those movements, you'll never be able to do those movements. And that's what the spine needs to be healthy. It needs to be able to do those movements. I think it's on the back of your t-shirt. Movement is medicine, isn't it?
Yep, movement is medicine. It's there.
I would add on to the top. I would add on to the top of that proficient movement, because if you move poorly, then it's going to damage you more. Yeah, I've seen lots of people.
Absolutely does.
Yeah.
Well, you see them on the table, don't you? That's the whole thing. You see the end result.
I see the end result on the table, and people who've just left it too late. And they've got gross instability, gross mechanical instability of the spine. They've got neural compression. They have weakness, sensory loss, neuropathic pain. And for those people, it's just too late. They do need a symptom-based structural intervention. But guess what happens as soon as they've had their symptom-based structural intervention, i.e. decompression stabilization surgery? They are straight into the functional movement program to restore their corrupted motor patterns. Otherwise, my surgery will fail. And that's kind of what's happening globally as well, is that people are saying, hey, don't do spine surgery because that surgery doesn't work. No, the surgery does work, but what's let them down is that after the surgery, they didn't correct the movement dysfunction that made them need the surgery in the first place.
They went back to smoking.
Yes, exactly right.
That's it.
100%, 100%. And who would do that? You would not get a lung transplant if you didn't sign a contract with your lung surgeon that I'm going to stop smoking. Or they won't even get in the door until they've stopped smoking. You won't get a liver transplant if you're still drinking alcohol. You'll just die with your liver cirrhosis. You won't get on the waiting list for a transplant if you're still drinking.
And so we need movement proficiency to be the biggest part of our healthcare system for lumbar spine interventions.
Exactly.